the age of the patient at which it occurs, therefore the aging of the population is a focus here. Male sex, the use of anticoagulants, which has changed pretty dramatically over the past 30 years. And the disease of cerebral amyloid angiopathy, which results in fragile blood vessels, which are more likely to rupture. And again, that relates to the aging of the population. The other two major risk factors are substance abuse and tobacco abuse, which are not our focus today. Next slide. What we have done in this study is focused on the incidence of intracerebral hemorrhage. We're not talking about traumatic, spontaneous intracerebral hemorrhage, and the mortality associated with it. And we looked at the period of 1990 to 2017 to see what we could associate those incidences with in terms of age, sex, and geographical location. Next slide, please. The study was performed using the Global Burden of Disease database, which is an international database. However, we focused our attention on health loss in the United States, 50 states and 1 territory. Now, for the incidence of the disease, the data came from inpatient billing data as well as outpatient visits. For mortality, we looked at the vital statistics of cause of death as well as autopsy data, and we abstracted those together to create a cause of death registry. And we included only non-traumatic intracerebral hemorrhages, and we specifically excluded subarachnoid hemorrhages. So again, we're just talking about rupture of blood vessels within the substance of the brain. Next slide. We use this global burden of disease database to come up with age standardized rates. And this is a particularly important issue because when you are, it's easy enough to come up with the number of patients who had a particular disease. When you try and reference that in terms of the proportion of the population, it's important then that you know what the size of the population is within that particular age group. So the GBD uses a standard population calculated as an average across all the countries of the percentage of the population in 5-year age groups. This allows you to determine an age standardized incidence rate as well as an age standardized death rate. Next slide. Another feature of the research is the joint point regression analysis. And if you look at this graph here, which is not our data, but just a sample, you can see there are multiple trends here. In the first portion, you see there's an upward slope. It then goes down, goes up again, and down again. And the regression analysis here allows you to look at the maximum likelihood for a change in slope over a period of time. So you could talk about trends in a particular 5, 7, 10-year period, depending on what the data showed you. Next slide. So the joint point regression analysis allows a quantitative expression of changes in slope, just linear slope over time, and you can get estimated annual percentage change trends calculated by fitting a regression line to each of those periods using a natural logarithm. Next slide. So you'll see some abbreviations. Just to recap, the age standardized incidence rate is essentially the incidence. The death rate is also age standardized. And then if you compare those two, you come up with a mortality to incidence ratio. So we're talking about number one, how many people are getting this disease? And number two, of those that get it, how many of them die? And then finally, we have the EAPC, which is the estimated annual percentage change. Next slide. The trends that we saw were that the incidence decreased by 18% in men and 16% in women in the study period of almost 3 decades. The incidence rate was 25.7 per 100,000 for men and 19.2 for women. So higher in men than in women, which is not surprising. And what we noted is that for both sexes, there was initially an increase until 96, and then a consistent decline until the end of the period. That decline was most rapid in the last 5 years. Next slide. The death rates declined as well by 28% in men and 22% in women. In 2017, it was 14 per 100,000 for men and 11 for women. So again, not surprising, women were less affected by this particular disease. The decline in death rates for men occurred primarily near the end, not all the way to the end. And for women, there was actually an increase initially and then a decrease in the middle period. Next slide. The mortality to incidence ratio decreased by 12% for men, 7% in women. So you're less likely to get the disease and you were more likely to survive it, which is good news. The incidence ratio was 0.54 for men, 0.59 for women, so not significantly different. And the decrease in that mortality rate occurred between, again, in that middle period, 2002 to 2010, and then subsequently an increase at the end, which surprised us. Similar pattern for women, the decrease 2001 to 2011, and then an increase again in 2011 to 2017. Next slide. So this is not the final conclusion of the talk, but the conclusions of this study that I'm going to discuss for the next few minutes is that we had overall declines in incidence, death rates, and the mortality to incidence ratio throughout the period. So that for patients experiencing hemorrhage, there was a lower survival trend for both sexes in the latter part of the study period, which again, that's the surprising piece. So while there's an improvement in incidence, mortality has worsened lately. Next slide. So what do we know? Well, we looked on state levels within the United States, and we saw that those with the highest levels of obesity, cardiovascular disease, substance abuse, and hypertension saw worsening mortality and mortality to incidence ratios. And that improvements in ischemic stroke incidence, which have been striking over the last 20 years, have not been matched by improvements in intracerebral hemorrhage in any state. So let's see what the potential underlying influences are. Next slide. So if we look at the prevalence of hypertension, we don't have that exact period, but we have some of that period. Overall, the prevalence of hypertension has been unchanged, but young adults saw larger increases in hypertension awareness, treatment, and control than did older adults. So the younger adults are more aware of their disease and are treating it more effectively, but the older adults are not doing as well. Overall, all of these trends were worse among young adults, meaning they were less likely overall to be aware that they even had hypertension and to treat it, but they did have improvement in that period. They didn't catch up to the older adults. All age groups saw improvements in control, but let's also keep in mind that the population is aging. So the people who are most susceptible to that disease are becoming more populous themselves. Next slide. We have graphs of these. The overall percentage of hypertension in the populations are remaining quite flat in all age groups, but we're seeing some improvements in control in the younger age group, more so than in the older age group, but again, they have not caught up yet. Next slide. Then there's anticoagulant use, all right? Keep in mind, you're hypertensive, you're more likely to have a hemorrhage. If you have a hemorrhage while you're on an anticoagulant, you are much more likely to die. So oral anticoagulant use, this is US and UK, but obviously relevant to our population. This use has climbed over this same period, this latter period we were concerned about in our study. And it's a dramatic climb, went from 10 million people to 17 million people, while the use of warfarin, the older anticoagulant, has fallen. The newer anticoagulants, such as rivaroxaban and apixaban, are accounting for most of these increases. Yeah, go ahead to that slide. And you can see the blue is declining, that's warfarin use, but the overall use of anticoagulants is climbing. Next slide. I will point out that there's some recent competing results. These just came out this year at the International Stroke Conference a few months ago. They saw the 3-year incidence of intracerebral hemorrhage rising from 2004 to 2018, which is not what we saw. And they saw it coinciding with increases in the prevalence of hypertension and anticoagulant use, as we did. And they saw that the intracerebral hemorrhage incidence was faster among those in the young age group relative to those in the older age group. Next slide. Here's their slides. You see the slope, particularly in non-Hispanic Blacks and non-Hispanic whites, climbing sharply. And the highest incidence, again, the increases, excuse me, not the highest incidence, but the increases came mostly in the younger age group, as we saw. Next slide. So why are these results different between what they saw and what we saw? They used only an in-hospital payer database, whereas we were looking at both in-hospital and outpatient registries, which I think allows us to capture patients who might have had a secondary diagnosis of intracerebral hemorrhage. They changed the methodology for their database in 2012, after which they saw this change in slope. And we believe our combined method for assessing both inpatient and outpatient visits is more accurate. And we think our combined method of recording registry from death registries as well as verbal autopsy data is more accurate. Next slide. Coming to our conclusions now. We think the reduced incidence of intracerebral hemorrhage overall is likely related to improvement in the control of hypertension in all age groups, and from the switch of the older warfarin to the novel oral anticoagulants like apixaban and rivaroxaban. We think the reduced incidence overall is driving the reduced death rates. Naturally, if you're having less of the disease, you're less likely to die of it. But however, those hemorrhages which do occur, which get through despite good hypertensive control, are more likely to result in death now due to the aging of the population, more frail group, and also that aged population is more likely to have cerebral amyloid angiopathy and not just hypertension, and therefore be more likely to have really devastating hemorrhages. Next slide. What we would like to do, therefore, is to tie the secondary diagnoses included in the registry, such as hypertension and cerebral amyloid, to the intracerebral hemorrhage primary diagnosis to see if we're correct about our hypothesis. And we'd like to look at state-by-state analyses of hypertension diagnoses, the age-related incidence, and compare that to the intracerebral hemorrhage incidence. And then finally, we'd like to look at efforts towards primary prevention of hypertension to see how that is affecting intracerebral hemorrhage rates. Next slide is just an acknowledgement to my collaborators, in particular, Drs. Delago, Singh, and Johnny, who were really the lead authors on this study in terms of the registry information. And with that, I thank you for your attention, and I am open to questions.
Thank you so much for your interesting talk. I feel that is too interesting. So the floor is open for the questions. If anyone having the question, feel free.
Hi, Dr. Gizzi. I have a question for you. And thank you very much for the presentation. And this is Dr. Bulut. I'm just wondering, what could be the reason of increasing in mortality incidence ratio in men between 2014 to 2017? Why that particular area doesn't fit the general trend?
I think that we're seeing increases, consistent increases in the US in obesity, particularly in the South, which is the stroke belt. And I think as hypertension is going up, the incidence of hypertensive hemorrhage is climbing with it. At the same time, we may be seeing increased incidence in the use of anticoagulants in the older populations. We're more effective in diagnosing things like atrial fibrillation. So those patients are more likely to be on an anticoagulant. And if they are unlucky enough to have a hemorrhage, they're more likely to die. If you have an intracerebral hemorrhage while on an anticoagulant, your chances of surviving are very poor.